Today, we're going to talk about a condition that was pretty much forgotten, but is now making a pretty startling comeback. It's called Lymphogranuloma Venereum, or LGV for short. And we're about to find out exactly why this forgotten disease really needs our attention right now. So let me just start with a question for you. Have you ever heard of the sixth venereal disease? How about the Durand-Nicholas-Favre disease? Probably not, right? Well, these are just a couple of the old school names for LGV, a disease that had a bunch of different identities before it kind of faded from public memory. So to really get a handle on why it's reemerging, we have to go back in time and get to know this historical foe a little better. Okay, so at its core, Lymphogranuloma Venereum is a sexually transmitted disease. Now, you've almost certainly heard of chlamydia, but LGV is caused by these really specific, much more invasive strains of that same bacterium. We call them serovars L1, L2, and L3. And these guys don't just stay put. They have this special talent for invading the body's lymphatic system. You know, the history of LGV tells a really fascinating story. It was first flagged as its own unique disease way back in 1913, and some big diagnostic breakthroughs followed over the next couple of decades. For most of the 20th century, people thought of it as a rare tropical disease. But then, 2003 happened and everything changed. All of a sudden, major outbreaks started popping up in Europe and North America, mostly among men who have sex with men, and just like that, this forgotten disease came roaring back into the headlines. So how does this bacterium actually pull off its takeover? Well, its invasion strategy is remarkably clever. Let's break down the life cycle of chlamydia. The bacterium basically has two different faces. First up, you've got the elementary body, or EB. Think of this as the infectious travel pod. It's small, it's tough, and its one and only job is to get inside our cells. But once it's in, it completely transforms into its second form, the reticulate body, or RB. This is the factory phase. It hijacks the cell's machinery and just starts making copy after copy after copy of itself. Okay, this diagram shows the whole 48-hour life cycle. It looks pretty complex, I know. It shows everything from the moment that elementary body latches onto a cell to the point where all the new copies burst out to infect more cells. But we can simplify this whole thing into 3 key steps. So the crucial thing to remember is this 3-step strategy. Step 1, attach and enter. The EB latches on and gets inside. Step 2, transform and replicate. The EB turns into that RB factory and starts churning out copies. And finally, step 3, burst and spread. The cell literally ruptures, releasing a brand new army of elementary bodies to go out and start the whole cycle all over again. This really aggressive life cycle leads to a pretty distinct progression of the disease, and it all unfolds in 3 stages. The first stage is unbelievably sneaky. It starts with what's called a primary lesion, usually just a tiny, painless ulcer right at the site of infection. But here's the catch. It's incredibly brief. It often lasts just a few days before it heals completely, without even leaving a scar. And because it's so quick and doesn't cause any symptoms, most people have no idea it was ever there. And just to put this into perspective, look at how the LGV ulcer stacks up against other STIs. A syphilis chancre is typically hard and leaves a scar. A chancroid ulcer is really painful. The LGV lesion, though, it's soft, it's painless, and it just vanishes. That subtlety is precisely what lets the infection get a foothold completely undetected. Then, weeks or maybe even months later, the second stage kicks in, and this one is a lot harder to ignore. The bacteria travel to the nearby lymph nodes, usually in the groin, causing them to get inflamed and painfully swollen. These swollen nodes are known as buboes. And this leads to a really classic clinical sign of LGV. When the lymph nodes both above and below the groin ligament swell up, it creates this visible dent or depression right between them. This is famously known as the sign of the groove. It's a huge telltale hint for doctors that LGV might be the culprit. Now, depending on where the infection started, the disease can show up as severe proctitis. That's inflammation of the rectum. This can lead to painful ulcers and fistulas, which are basically these abnormal tunnels that form between an internal organ and the skin. This clinical image here shows an example of that kind of damage. And if the infection is still left untreated, it can move on to the devastating 3rd stage, sometimes years down the road. This chronic inflammation causes a lot of scarring and fibrosis, which can lead to rectal strictures, a really dangerous narrowing of the rectum, more fistulas, and even genital elephantiasis, which is a severe swelling of the tissues. This is the tragic, long-term result of a forgotten infection. Wow. So with such a sneaky presentation, how do clinicians actually figure out what's going on? How do they diagnose this culprit? Let's dive into the investigation. Diagnostic tech has come a very, very long way. We've gone from the old fry skin test from 1925, which wasn't very specific, to antibody tests in the 80s, and now, finally, to today's gold standard, nucleic acid amplification tests. You might hear them called NAATs. These are incredibly accurate DNA-based tests. So, the modern process is a really simple two-step confirmation. Step 1. A standard test checks for any Chlamydia trachomatis DNA. If that comes back positive, then Step 2 uses the exact same sample to run a more specific test that looks only for those L1, L2, or L3 strains that cause LGV. It's a super effective way to pinpoint the exact culprit. Before we had these modern DNA tests, doctors actually used cytology, which is just looking at cells under a microscope. And here you can see what they were looking for, those chlamydial inclusion bodies. Remember those factories of reticulate bodies we talked about? Inside the host cells. They'd use stains like Giemsa and iodine to make these little bacterial colonies visible. All right, now for the good news. Despite all these potentially severe consequences, there is a resolution. LGV is totally treatable. So let's take a look at how it's managed. The number one treatment is a 21-day course of the antibiotic doxycycline. It's highly effective. There are other options like erythromycin or azithromycin, especially for pregnant women. But the most crucial thing to take away here is that LGV needs a much, much longer course of antibiotics than a standard chlamydia infection to actually be cured. So what are the biggest takeaways here? First, getting treatment early is absolutely critical to stop the disease and prevent any permanent damage. Second, and this is huge, to break the chain of transmission, all recent sexual partners have to be tested and treated too. Third, following up with a doctor is essential to make sure the infection is totally gone. And finally, it's a really important opportunity to retest for other STIs. And this brings us to one last, pretty sobering fact that shows exactly why LGV awareness is so important today. In recent outbreaks, the rate of co-infection with HIV among patients with LGV has been as high as 80%. You see, the ulcers that LGV causes can make it much, much easier to either transmit or acquire HIV. This connection locks the two infections together, making this forgotten disease a very, very modern threat. Which leaves us with one final question. With its stealthy beginning, its potentially severe complications, and its strong connection to the spread of other infections, isn't it time this forgotten disease was finally brought back into the light and remembered?